everyone, and welcome to today's Public Health Ontario Rounds presentation on the topic of advancing engagement in antimicrobial stewardship through effective communication strategies. My name is Brad Langford. I'm a pharmacist specialist at Public Health Ontario, and I have the pleasure of moderating today's session. First, I would like to acknowledge that I'm speaking to you from the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, which is now home to many diverse First Nations, Inuit, and Métis peoples. While we meet today on a virtual platform, I invite you to take a moment to acknowledge the Indigenous peoples of the land in which you are on today and the importance of the land in which we all call home. This week is World AMR Awareness Week, which is held annually each year from November 18th to 24th. World AMR Awareness Week is a global campaign to raise awareness and understanding about antibiotic resistance and to share ideas and knowledges about ways that we can all address this public health threat. In particular, one approach we will be discussing today is antimicrobial stewardship. As part of this campaign, Public Health Ontario has launched some new resources to highlight the important role that public health professionals play in antimicrobial stewardship. This includes a detailed map illustrating the volume of antibiotic use in each of Ontario's public health units and a list of strategies for local public health participation in antibiotic stewardship. These resources can be found on PHO's website at publichealthontario.ca/ASP. And as many of the audience here knows, antimicrobial resistance is often referred to as the silent pandemic. So to help increase the visibility of this threat, there is a national color campaign called Go Blue for AMR. During World AMR Awareness Week, we encourage participants to wear the color blue, use blue backgrounds like the one that we have here on social media and during webinars, and to visit one of over 50 landmarks across Canada that will be illuminating in the color blue on November the 24th, this Friday. And of course, to share with family, friends, and colleagues about why you are going blue to support antimicrobial resistance efforts. More information on this campaign is available at antimicrobialawareness.ca. So before we begin, I do have a few housekeeping items. First of all, the chat pod has been disabled to limit any distractions during the presentation. So please use the Q&A pod if you have any questions. A discussion and question period will follow the presentation. And if at any point during the presentation session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state, as the moderator of this session, I have no conflicts of interest to declare. So it is now my great pleasure to introduce the speaker for today's presentation, Dr. Julie Simsak. Dr. Simsak is an associate professor at the Division of Epidemiology at the University of Utah School of Medicine, where she co-directs the Utah Quality Advancement Laboratory. Dr. Simsak is a medical sociologist with expertise in the social and cultural determinants of decision-making and behavior in healthcare organizations. She is an internationally recognized expert on the social behavioral dynamics that shape antimicrobial use across clinical contexts in human and veterinary medicine, and in the application of implementation science frameworks to research in antimicrobial stewardship. So without further ado, I'll pass it on to Julie to begin.
Great. Thank you so much, Brad, for that wonderful introduction and the invitation to present to you today. So I will start by saying I have no financial relationships to disclose in relation to this presentation, and here is a disclaimer. So, my talk today really has three objectives. And I'm really going to be leaning into my professional identity and interest in thinking about the delivery of healthcare as a social scientist. So, I'm going to start by summarizing the importance of social dynamics for change in healthcare with respect to antibiotic stewardship. Then, I'm going to talk a little bit about some common communications in antibiotic stewardship and then describe strategies to communicate effectively with prescribers and with patients to improve antibiotic prescribing. But to set the stage and really help you understand the vantage point that I use in all of my research and advocacy around antimicrobial prescribing and antibiotic stewardship is I need to sort of take a step back and acknowledge sort of all of the work that I do around quality improvement, which really stems from this belief that when we talk about transforming how care is delivered, we're really talking about social change. And in early research that I conducted as part of my PhD in sociology, I did work with infection preventionists who worked in hospitals to try to prevent patients who were hospitalized from getting infections. And this particular infection preventionist who had an MPH and was really passionate about public health talked a lot about the work that she did and what it involved. And so she says, I went into this line of work because I was interested in infectious disease epidemiology and hospital outbreak investigation. I love statistics and the use of epidemiologic methods in infection control. When we see an uptick in MRSA in our ICU, I like to be a disease detective within my own hospital to figure out the source. And while all the tools I learned in public health school prepared me for that aspect of infection prevention, I didn't realize how much of it would be people management. So, yes, our work is about microbiology, epidemiology, infectious disease, and applying the best scientific evidence to control the spread of infection, but it's also about managing, cajoling, and sometimes nagging people to do the right thing every day when they come to work. My MPH coursework did not prepare me for a lot of that. So much of my job is trying to change hearts and minds, and I find that to be the most difficult thing. And I thought this was sort of a really perfect quote from an interview I did with this individual and many professionals in this field who really talked about sort of the challenges of making change in complex healthcare organizations and how it can be common to sort of focus on the technical aspects of change while not giving as much attention to the social aspects. And I think this is a really critical lesson that we can learn when we look at sort of the near history of patient safety and quality improvement broadly, and the importance of acknowledging these social dynamics, or what has been called by Peter Pronovost adaptive dynamics around change. And I wanted to just take a brief detour into a story about a particular infection prevention success story that I think really makes this point very clearly. And again, will set the stage for the conversation I'm going to be having with you today about conceptualizing antibiotics as a sociologic phenomenon. And so this is a particular sort of cautionary tale that I really like alliteration. So I'm calling it central lines, checklists, context, and collective social action, a bit of a mouthful. But this is a story about a very bright spot in the patient safety social movement, particularly in the United States. And it's the story of the sort of metabolism and dissemination of a particular intervention that was an early patient safety success story. And this is the manuscript from the New England Journal of Medicine that reported on the results of this intervention that was intended to try to reduce the number of central line associated bloodstream infections that vulnerable, critically ill patients in ICUs were getting. And this was a medical harm that was very common, very devastating, and was one of the first in which an intervention was able to demonstrate success. And this intervention was sort of very, very successful, got a lot of attention, a lot of excitement. And when you look at sort of the public interpretation of this intervention study that was done throughout a series of ICUs in the entire state of Michigan, the way that the sort of public story of this particular study was told was that it focused on one particular element of this intervention, which was a central line insertion checklist to try to ensure that all the proper infection prevention techniques were used at the time that these patients were getting this very invasive device put into their bodies when infection was likely. And when you look at sort of the way that this study was described and talked about, I think probably one of the biggest champions and most enthusiastic proponents of it was the surgeon public writer, Dr. Atul Gawande, who in this New Yorker article, I love the headline because it's the checklist. If something so simple can transform intensive care, what else can it do, right? He even wrote an entire book about this. And what's really interesting is that an overemphasis on the checklist, which is what happened after this study came out and people got really excited about the fact that it worked, was that people really attributed the success of this intervention to this checklist, right? But if you only focus on the checklist in telling the story of this study, it absolutely obscured a number of social mechanisms that actually were important to driving change and reducing the rate of these infections. And so a number of scholars, sociologists, and the physician leader of this particular intervention actually did a post hoc analysis of the dynamics of change within this study and found that there were a number of elements at play that drove success, including hospitals that had engaged leadership. So the sites that did better had leadership that were very committed to the work. The ICUs participated in this collaborative, which developed this own sort of social network that encouraged hospitals to sort of learn from each other, but also to what we call in sociology, develop this fancy term of institutional isomorphism, which essentially means keeping up with the Joneses, or, well, if that hospital can do that, then we can as well. The data that were used in the collaborative were publicly sort of shared with each other to try to promote accountability. There was a change in attitude about what these central line associated bloodstream infections meant. So, ICU clinicians reported that before the intervention, there was the sense that, look, these patients, they come to us, they're critically ill. We're using this tool to try to keep them alive, and some of them are going to get infected. It's just the cost of doing business. To sort of a real reframing an attitude to this idea that this outcome was unacceptable, right? And if you think about it, the way that someone sort of perceives an outcome from the cost of doing business to unacceptable patient harm is going to change their motivation, right? And that is a inherently sociologic concept. And then finally, related to the actual checklist itself, right? The checklist itself is simply a tool. Maybe it's a piece of paper, maybe it's a screen embedded in an electronic health record screen, but people have to enact the tool. People have to make the tool do the work, right? And so in hospitals that did better, it was found that there was a climate where nurses, who were the ones who were frequently filling out the checklist while a physician, an interventional radiologist placed the central line, were able to observe. And if they saw a breach in practice, they could actually speak up and say, hold on, you need to use the sterile drape in this way, right? If that social dynamic wasn't present, then the checklist doesn't do anything, right? And what we saw in the years following this study and in the sort of enthusiasm for checklists, that if you implement the checklist without paying attention to the humans around it and the dynamics that drive improvement, that you will have failed replication of these effects at other sites. And so this really gets into this idea of adaptive and technical problems when we talk about quality improvement and improving patient safety in complex healthcare settings, where we're focused a lot on the sort of technical challenges. So getting the equipment, tools, and supplies that we need, data, having valid measures, having evidence and guidelines to sort of to tell us what should be done, and of course, access to technology. But we also know that there are all kinds of adaptive challenges related to the local context and culture of an institution, the emotions and psychology of those who are involved in delivering and receiving and overseeing care, the social and political dynamics of healthcare institutions, and the priorities, beliefs, habits, and loyalties that individuals are manifesting in the course of their work. And so, as a sociologist who studies healthcare organizations empirically, I think of these institutions as essentially small societies. Because when you think about it, clinical work is about people who are working together on sick people, right? And patients are interacting with clinicians and interacting with each other. And we know that the behavior and the way that people do what they do in these organizations are shaped by the social dynamics of groups. So the navigation of conflict, of hierarchy, emotions, the professional identities that individuals have in delivering care, as well as the identity of what it means to be a patient, and then the management of uncertainty and risk. And we know that these different contextual settings have different cultures and drivers of practice that really have nothing to do with sort of the application of biomedical evidence, but in sort of keeping up with social norms. And so that's the sort of overarching framework I want to just start with in terms of what I sort of come to the table with. And when I think about the problem of antibiotic resistance and antibiotic overuse and interventions at different levels to try to change how antibiotics are used. And so that leads me to this question. So what is a sociologist doing researching antibiotics? And I want to share another excerpt of an interview that I did. This was also during my dissertation, which was a fascinating project about hospital acquired infection. But I was conducting an interview with a pediatric general surgeon who explained to me some of the confusion around determining whether an infection following surgery is associated with the surgery or something else, or is actually even an infection, and said something about antibiotics that really piqued my interest for my future research. So this surgeon says, if I see a patient a week after surgery and there's still a little redness and mom's nervous, I'm inclined to just put the kid on the antibiotic. It just makes everyone comfortable. And then a week later, the redness is gone. Did I treat an infection or was there just some redness, some inflammatory postoperative discharge? I don't know. I'm more careful about how I give antibiotics than I used to be in the past. You don't want to be part of the societal issue of creating superbugs, but it's surprisingly difficult to look mom in the face when she's convinced it's infected and you're trying to say, look, it's not infected, when you don't even know for sure yourself. And a week later, it could pus out, and mom's like, see, should have put her on antibiotics. I can't believe you did this to my kid. That's what you imagine the scenario being if you don't do something. It's so much easier to say, look, we'll put her on a little antibiotic. And what is expressed in this comment from the surgeon is really this theoretical framework that I bring to all my work on antibiotics, which is acknowledging that the act of prescribing a medication is a social act. It's a way for a clinician to communicate, to demonstrate concern. It expresses power and facilitates social control. So if a medication is a solution, in that is a definition of a problem. It can produce income. There's financial ways in which prescribing, why prescribing happens the way that it does. And when we think about the role of the prescription within the sort of flow of clinical care, it's a tool for a clinician to sort of navigate practical challenges in care delivery, right? So how to react to patient demands, how to show that you know what you're doing, maybe if you don't, even if you don't, how to manage uncertainty about what the problem is, and really how to end the clinical encounter, right? So symbolically, the offering of a prescription is sort of wraps up that clinical encounter. And so this is sort of where I've really anchored my research on antibiotics in. And this is a conceptual model I've developed that really intends to sort of put the decision to use the antibiotic in the center here and sort of framing it by a number of different factors that shape sort of that decision making. And the boxes in blue are really what I'm talking about today, which really relates to what I call the social determinants of antibiotic prescribing, which include the relationships that clinicians have with each other, the relationships between clinicians and patients, clinicians' risk, fear, anxiety, and emotion around decision making, the way they perceive the problem of antimicrobial resistance and overuse, and sort of the contextual factors that shape decision making. So communication matters critically when we think about these social determinants because the mechanisms that underpin these relational dimensions of antibiotic prescribing happen through communication, right? And so I want to start by talking about the relationships between clinicians, particularly the relationships and the communication between professionals known as antimicrobial stewards, who many of whom are based, in different kinds of organizations whose job it is to use varying approaches to encourage prescribers to use antibiotics more judiciously. And their work, again, we can focus so much on the technical nature of the work of antimicrobial stewards, but communication is key to what they do. And I want to get into a little bit of detail about some research that I've done about this phenomenon, in particular, coming up with some strategies that can potentially help stewards engage more clearly with prescribers. And so when we think about antimicrobial stewardship interventions as they're described in the literature, particularly, again, those that are hospital based, but I've increasingly seen efforts in the more outpatient setting that also rely on communication, that these interventions, they shape prescribing via communication, right? So, prospective audit and feedback, where a steward perhaps, contacts a clinician when the laboratory results are back on a patient to say, look, you can stop that antibiotic, or perhaps you should switch to a different agent. In some hospitals, there are sort of authorization schemas where prescribers have to go to a steward to get approval to use a drug. And then there's this newer approach named handshake stewardship, where essentially stewards go on rounds and interact in a sort of, informal way with clinicians to sort of gently encourage them to change how they use antibiotics. And it's increasingly recognized that, stewardship personnel need more than proficiency in infectious diseases, microbiology, pharmacy, data and informatics. They need these social and communicative skills. And, again, when we talk about the sociology of antibiotic prescribing, stewards are navigating really complex social and cultural dynamics in their daily work. In some ways, you can think of this as them delivering advice to people who haven't requested it. They may be thought of as playing a gatekeeping or a restrictive access role. And they have to contend with this sort of norm of non-interference that exists within the culture of prescribing, where clinicians generally are not questioning each other about their antibiotic prescribing choices. And this has led to many of them sort of getting the unfortunate moniker of the antibiotic police. And so here's an excerpt of an interview that I did with a pharmacist who works in the ICU at a children's hospital, and described an observation of about their ID pharmacists. I've noticed something when I've been rounding with the team. So our ID pharmacists are part of the antimicrobial stewardship team and rotate on and off. One week they'll be doing stewardship. The next, they're on service rounding with the team. And there'll be physicians that see these pharmacists rounding with the team, and they'll see them approaching. They're like, oh no, what did I do wrong? And the ID pharmacist says immediately, oh, I'm not doing stewardship. I'm on inpatient service, or we're not coming after you, right? And so I thought this was very interesting because it indicated sort of this identity work that stewards are often doing if they feel that their work is really is this incursion into these social norms. We also know, again, this is about interprofessional communication, right? And so you have pharmacists, you have physicians, you have trainees, that there can be all kinds of asymmetry in authority and accountability. Of course, these hierarchical structures that shape how clinicians do their work, and that the act of prescribing, as I mentioned earlier, has this emotional element, right? And so the stewards are trying to navigate that emotional driver. And so, why does this matter? Well, interestingly, when you look at the impact of communication based stewardship interventions, that there is a wide variation observed in how well they work, right? And so, for example, prospective audit and feedback, where sort of if the outcome is the number of recommendations that are agreed with by the prescriber, it ranges widely in the literature from 11% to 90% agreement. And we know that there are some factors associated with acceptance related to communication dynamics. So the face-to-face communication, the role of the steward and how that matches with the prescriber, the type of recommendation that's made. So not surprisingly, recommendations to stop antibiotics are accepted less. Sociodemographics of the steward, including gender and sort of where the patient is located within the hospital. And we also know that this matters for the work of people doing antibiotic stewardship. And I'm personally very committed to and interested in the well being of stewards, because we need these individuals to do this work. And if we lose them from the profession, we are going to lose a lot of institutional knowledge. And so having these frustrating conversations day in and day out can really take a toll and produce occupational burnout. And so while communication is important, we really lack an understanding of sort of the specific attributes of effective communication and stewardship, both how stewards communicate and how prescribers perceive this communication. And so this was the sort of motivation and background for a study that I conducted with a number of colleagues at multiple institutions in the United States that was funded by the CDC, that really sought to answer those questions. And so I want to move through this efficiently and present the results because I also want to end the talk today talking a little bit about communication with patients. But this was the result of a multi-site qualitative study that my team and I conducted in 10 hospitals across the United States. And we looked at community hospitals, academic hospitals. We talked to pediatric clinicians, and we really wanted to do an in-depth interview study on communication dynamics in stewardship. So we conducted interviews with 146 prescribers in different clinical settings, as well as stewards. And we did gather these data before COVID-19, so that's an important thing to know. But when we analyzed the way that the prescribers in our study felt about communication and stewardship, they were largely positive. So over half felt positively about stewardship communication. 32% were mixed, and there was a small number that felt negatively. But what's interesting and important is to look at the reasons that they gave for why they felt the way they did about stewardship. And so when we looked into the data and looked at what it was about clinicians' perceptions that why they felt negatively towards stewardship, there were a number of sort of key findings. The first is that they found that stewardship symbolized more unpalatable trends in medicine more broadly. So, this sense that stewardship was just another way that bureaucracy was sort of encroaching on their decision making. A lot of them who felt negatively thought that stewardship was about cookbook medicine. Many of them described it being a threat to their professional identity or sense of self, suggesting that they really did not like to feel like they were wrong and that their expertise was not being acknowledged. And really, sort of, again, the goals of stewardship and the goals of the prescriber appeared to be at odds. And this really came from the sort of perception of motivation about what is it that we're doing here in providing clinical care. And so I wanted to just share one example of an interview quote from an intensivist, a critical care doc at an academic hospital, who explained it this way. I feel like when physicians, not ASP, but in the critical care world, I feel like we're just trying to get these patients to the next day and to keep them alive for the next day and to keep going. So we play it minute by minute. We don't tend to look at the long term until they're kind of out of the woods. When we're putting on a broad spectrum antibiotic and want to keep it on for 7 to 14 days, but know we're going to have to get ID's blessing, I think that's where it becomes tense. When stewardship is trying to make a recommendation based off their evidence base, and the physicians in the ICU are trying to make a recommendation based off just their experience and just trying to get this patient to the next day, right? So it's this different sort of perception about what are the goals of this thing that we're doing. And those who felt positively about stewards, explained that they felt that stewards communicated things of value in a thoughtful manner. So, education, updated evidence, sort of the catching of errors. They felt positively if they felt that stewards attempted to understand where they were coming from by adopting a non aggressive approach and acknowledging the prescriber's experience, both clinically, but also with the patient in question, and thought critically about when and where to interject, and really conveyed this shared sense of mission and motivation, right? And so here is a critical care nurse practitioner who says, I always think of antimicrobial stewardship and infection control in the same way. Like, those people, do they have hearts, But in my current hospital, the stewards definitely have hearts. At my previous institutions, they were curt. Well, why is this person on Vanc? Stop. They were pushy, and it almost felt like a contest. They wanted to win. They came with their weapons. Here, we actually have a discussion. They let us explain our thinking, right? And so when we talked to stewards, we found a lot of really nuanced information about the way they thought about communication. And the top line summary is that, there was a lot of thought that went into the purposeful use of language about how they communicated with prescribers to reduce defensive reactions. They cared a lot about what we think of as framing, where they thought a lot about the intent behind the message and the way that the person who would receive their message might respond to that message. And I want to just provide an example of a physician steward at a pediatric hospital who I think beautifully describes this in kind of a humorous way, where they said it's important to acknowledge the prescriber's expertise. If you come in as a super expert, that torpedoes the whole thing because those people are practicing a craft just the same as we are. And if you come at it from a standpoint of, well, let me show you how it's done, then you're going to be miserable and they're not going to like you. Having the emotional intelligence to say, you're preparing to exert the Hawthorne effect on them, and nobody likes that. Nobody likes when mom comes over and checks to see how you're folding the underwear. She's probably not going to be like, "Oh, it's so great. Great job. Have you thought about folding it this way?" You're not there to second guess. You're there to understand and help them think through a problem because you both have the same goal in mind, which is taking as good a care of that patient as possible, right? And so we found that there was this real thoughtfulness about the way in which their communication would be received. And the final point that I wanted to make is they talked a lot about strategy and communication, and they thought about their communication as interactions that were happening over time, that each conversation was not a one off, but that their conversations were chains of interactions. And so what we really found from this study, right, is that prescribers generally felt favorably towards stewardship, but that communication that they felt positively about was not dogmatic or aggressive or agenda driven, conveyed a shared sense of mission and a desire to understand. And stewards really echoed this in the way that they talked about their purposeful and multimodal approach to communicating with prescribers. And they really thought a lot about relationship building. And so in summarizing these results, my team and I have sort of come up with what we think of as the 3 Cs that are partnered with the traditional 3 Ps and 3 Ds when you think about making stewardship recommendations. So, place, pathogen, patient, drug, dose, duration, but then we also want to think about the 3 Cs: context, communication, and collaboration. And again, you're going to have these slides, so you'll be able to go into some detail about this. But the point is that we think of communication purposively. We think about who should be communicating, how they should communicate, and in what context will people be seeing and receiving the messages. And then this idea about collaboration and the importance of thinking about interactions as investments in the future, and that you're really trying to build trust over time. And so, to finish off the talk, I want to now turn to another domain of communication that matters. So, that was very much about sort of prescribers and specialized stewards in a hospital setting. But we also know that a major social determinant of antibiotic use is the relationships between clinicians and the patients that they're taking care of. And so, when we think about the clinician patient relationship, when you actually talk to clinicians about why might you use antibiotics inappropriately, they almost universally identify patients' expectations and overt pressure for antibiotics as a key driver of why they use antibiotics, even though they don't think they're needed. And this is particularly true in settings where there are sort of that clinician patient one-on-one interaction or sort of this faster interaction. So in pediatrics, it's been reported in urgent care, the emergency department, over telemedicine, really in these outpatient settings. And so here's a primary care pediatrician who I love this quote because they beautifully described how it felt. Sometimes you just don't have time to argue with a parent, you just don't. It can be a war zone. It's in the middle of winter, and the kid is outside throwing up in the hall, and the mom says, "I need an antibiotic prescription." Most of the time, you can reason with her. You say, "Look, we don't need to treat this." And she says, "But my neighbor says this. I have an uncle who's a doctor, and he said, yes, I need it." They come up with a million reasons why they need it, and you just don't have time, right? And so, this war metaphor, which in all of my years of interviewing clinicians gets invoked more often than I might have thought at the beginning of this, I think beautifully demonstrates what this sort of the phenomenology of experiencing this pressure. And when we look at the literature on this relationship, which clinicians will often invoke, whether or not patients are more satisfied with their visits if they receive an antibiotic, it varies across studies. And so we do know that patients who go into a visit expecting to receive an antibiotic are more satisfied when they are prescribed one. And we also know that when the clinician perceives that that patient expects an antibiotic, they are more likely to prescribe, right? So this sort of interaction, the expectations, the social dynamic is driving decision making. But interestingly, there is evidence to suggest that clinicians actually have overestimated patient demand for antibiotics in a number of situations, and that patients are becoming more aware and wary, frankly, of antibiotic overuse. And in many cases, when you sort of dive into their feelings about antibiotics, mostly what they want is clarity about their symptoms, reassurance, information about what they should be watching out for as they move forward. Now, that doesn't necessarily mean that there aren't some very aggressively demanding patients, or as one of our studies is titled, inconvincible patients. But there's demonstrated evidence that clinicians may be prescribing on the basis of perceived rather than actual patient expectations. And I think that this is an indication and really makes a compelling case that communication really, really matters, right? And so there's a really great body of research that actually comes out of pediatrics in the United States, an investigator named Dr. Rita Mangione Smith, who's done some great work. I have some references at the end of these slides, but I wanted to talk about some work that a colleague and I have done about sort of this issue of patient appeals or demands for unnecessary antibiotics, and to really talk about sort of the content of these patient appeals and what makes them hard to counter, and then with some suggestions for how these appeals can be countered, how clinicians can sort of address sort of the meaning behind their messages. And so it's thinking about communication in that manner. And so this is the paper, and I'm just going to go through the sort of summary of what we come together with this paper. So this is a paper that I, as a sociologist, put together with an infectious disease physician and a general internist to really talk through the common appeals that patients have for antibiotics that aren't needed. So the first appeal that we identified is that, where patients have an observation when they come to their clinician that in the past, another clinician has prescribed antibiotics for a similar symptom, right? Well, Dr. Smith always gives me an antibiotic when I have symptoms like this, right? This is a hard appeal to counter because it involves sort of correcting the behavior of somebody in the past. It's very awkward. Patients have their own personal experience with this. And so, a way that a clinician can address this is to say something, well, it's helpful to know how you've been treated for this in the past. I'm focused most intently on how you're feeling today. Also, there's been more recognition lately about the harms of antibiotics. All physicians are being urged to use antibiotics only when they are more likely to help than hurt. Another appeal is this idea of past symptom relief, right? So patients may believe that, in the past when they had this congestion, they had antibiotics and they felt better fast, right? Which we know that may have nothing to do with the antibiotic, but patients perceive this to be the case, right? So when I've been sick like this in the past, antibiotics were the only thing that worked, right? And countering this is hard, again, because you're having to sort of correct their beliefs, which takes too much time. And so one way you can respond to this appeal is to say, you have a virus and antibiotics don't fight viruses. What you experienced in the past was the natural resolution of your illness. Your body has an amazing capacity to heal itself. Also, we want to avoid putting a chemical in your body that cannot help but could hurt you, right? It's about anchoring on what the diagnosis is, that antibiotics don't work, and really framing it about like the harms of unnecessary antibiotics. The third appeal is a very pragmatic one, and I think is something that even as a patient, sometimes you might feel an inkling where a patient essentially says, I've got this important life event coming up, and I don't want my symptoms to interfere with that. So, doc, we're going on vacation for 10 days starting tomorrow. Couldn't you just give me something just in case, right? And again, there's a real sense of humanity of like, I get it, you aren't well, and maybe there is the potential that this is bacterial, even though I don't really think it is. And so, sort of this negotiation. And so, a way you can sort of counter this again is anchoring on the harms of unnecessary antibiotics. So, you could say antibiotics won't help you get better faster, and they can cause problems like diarrhea that might ruin your vacation. There are some effective things you can do to manage your symptoms, including staying hydrated, taking ibuprofen, and saline nasal spray. The fourth appeal is this sort of invoking the collective or invoking one's social network, right? So observing that somebody in your life, your spouse, your child, your colleague, or someone they've spent time with has experienced similar symptoms and was prescribed an antibiotic by another clinician. Here's another case where sort of the behavior of some other clinician that may have nothing to do with that individual prescriber is shaping the expectation of these patients. And so a patient who says something is going around my office and everyone is sick, Many of my colleagues have been given an antibiotic for this and seem to be better, so I think I need one too, right? And so this is again a difficult appeal to counter. So a way you can address this, my chief concern is your well-being since you're my patient and I will treat you as an individual. My examination shows you have a viral infection. The fact that your colleagues are sick makes it all the more likely that it's a virus, and antibiotics don't fight viruses. Again, it's sort of emphasizing the focus on them and not on what some other clinician has done for someone else, and on the fact that it's a virus and antibiotics don't work to fight viruses. And then the final sort of patient appeal, and this is something that I have found to be particularly true for clinicians working in the United States in urgent care settings where they have, an urgent care on every corner, and patients can go in and they may have no relationship with the patient, where the patient makes a real economic or consumerist appeal for why they should receive an antibiotic. So, I took a whole morning off of work to come here. Are you telling me there's really nothing you can give me, right? Again, this is difficult because you do know that that patient took time off work. You do know that they're going to have to pay for that interaction, right? And so a way you can sort of respond to this appeal is, I'm so glad you came in to see me today so I could evaluate these uncomfortable symptoms you're experiencing to make sure it's not dangerous. You're sick with a virus. Well, we can't make the virus go away faster. You can feel better soon by supporting your body with rest, lots of fluids, and ibuprofen for your muscle aches, right? And so when we think about these appeals, I wanted to go into some detail about them because it demonstrates again that sort of prescribing is a social act, right? And in these social interactions and expectations that clinicians are navigating in these potentially very busy, time constrained, stressful moments, right? And so, what my colleagues and I recommend, we recommend some messages that really should be anchoring the meaning of these communications in the same way that sort of when we think about the steward's communication with prescribers that the patient's well-being is of the utmost importance. Here are some ways you can sort of think about communicating with patients. And so again, making sure that it's clear that the patient's well-being in that moment is the primary concern and the motivation behind the recommendation, to acknowledge that the patient's suffering is real. So again, if the prescription is sort of an indication that you're acknowledging the suffering, there are other ways you can do that that don't involve a prescription. Empathizing with the patient about the burdensome impact of illness on their daily life. Again, it can be hard when you see a lot of patients with the same sort of, respiratory viral illness that's not so bad, but they are really suffering. And remembering that, like, even if this is not so clinically serious, it's very, very uncomfortable. And then affirming the patient's decision to seek medical attention to rule out more serious illness again, and not having sort of an attitude like, oh, why did you even come in here? There's nothing I can do for you. And again, this is us focusing on the content of these sort of patient appeals. But also I wanted to acknowledge that there is other literature out there about even more sort of nuanced communication strategies that clinicians can use with patients around how they present their diagnosis and their findings. But this is just a way to highlight again that the content matters of communication. So I want to wrap us up and make sure we have enough time for questions. So I was sort of a rapid tour de force through communication and stewardship, both stewards communicating with prescribers and prescribers communicating with patients. And I think really I hope I've left you with the idea that if we want to think about improving how antibiotics are used, we have to engage with the social, behavioral, and cultural drivers that make prescribing sometimes the easier, more socially palatable thing to do. That the interactions that's occurring between stakeholders, clinicians, patients, public health professionals, antibiotic stewards, it really matters because it affects people's beliefs about antibiotics, their role in health and illness, antibiotic resistance, and that if we really pay close attention to the communication dynamics that exist in different contexts, that we can find really, I think, powerful insights about the best way to approach stakeholders to sort of change those hearts and minds, right? So I'm happy to wrap up there and take any of your questions. Thank you.
Awesome. Thanks so much, Julie. That was an excellent presentation. Really fascinating work, and it really highlights how complex and dynamic the field of antimicrobial stewardship is. It's not just about being an infectious diseases expert. There's so many subfields to it, and you really highlighted how sociology and communication skills are really key. So we do have some time for questions. So please enter your questions into the Q&A pod if you haven't already. Um, I'm just going to take a quick opportunity to ask a question myself, if that's
Yeah.
okay.
Yeah.
You talked a lot about, communication with teams and with patients. Um, it's really helpful for the day-to-day work of stewards. But
Hmm.
one challenge that stewards are often facing is trying to push our agenda forward. For example, trying to get new resources, getting buy-in from, senior leaders, etc., the C-suite policymakers. So, do you have any pearls on communication with those decision makers and how we
Yeah.
can help push that agenda forward?
Absolutely. And I think there are, part of this, and this is really kind of a basic thought and communication theory is, right, who is your audience, right? And we know that communication with clinicians may be different than the C suite, for example, and sort of thinking about sort of the what is motivating those individuals, what are the sort of what's their bottom line, and so trying to connect the impact of stewardship on the things that are concerning to them, right? And so we are increasingly in a regulatory environment where this kind of work is being used to judge and evaluate hospitals. So connecting it to that. My stewardship colleagues were very clear that they never talk about money with prescribers, but they do talk about money with the executive leadership, right? And again, it seems obvious, but it's an important point of thinking about what drives the sort of gatekeeper power brokers and what do they care about and connecting the messaging to those outcomes. And really I think, and this is something that, beyond the work that I've been doing at the real micro level in clinical settings is figuring out how at the policy level we connect antibiotic use and antibiotic resistance to direct patient harm and really do a better job of quantifying that and trying to demonstrate value of stewardship in terms of sort of the way in which these decisions actually accumulate and cause harm. And I think that's a work in progress still, but it's really again about figuring out what is motivating the person whose message who you are delivering the message to and taking that seriously and taking that into account. And I think in clinical settings, particularly a lot of stewards I've worked with who are maybe data geeks and they're very interested in microbiology and like making that business case can sometimes take a little bit of extra effort, but it's important to get people to listen to you. So that's a great question.
Thanks so much. So we do have some other questions from participants. First question is, you mentioned that some of your work was conducted prior to the pandemic. Do you think that anything has changed since the pandemic regarding patient
Yeah,
understanding?
yeah. So that's such an important and interesting question, and I've done work since. And I do think, I can't answer it conclusively. I do think that I think the globe is just a lot more aware now of what a virus is. I think sort of the concept of what a viral infection is something that the general public is more aware of. And, I also think that there is a whole sort of group of people who during the pandemic because they wanted to avoid engaging with clinical sites of care maybe had respiratory illness that it resolved without needing antibiotics, so maybe some of sort of the expectations around antibiotics have changed. So I think that there's likely some changes there. I do think unfortunately a lot of the stewards that I've done work with were called into service to do things with COVID therapeutics and got really burnt out and actually are having trouble like continuing on in their stewardship work. So I think there may be some positives in terms of helping the public understand what a virus is, but I also think there have been some negatives, particularly in the work of stewards and sort of their own well-being. And yeah, but it's a really good point, and I don't have hope that it's going to change for the long term. I think people sort of fall back into their habits and the memory of the pandemic even feels like people are sort of not invoking as much as they used to, but it's a critical question for sure.
Next question is, uh, res- participant is asking if you're curious about, uh, they're curious about if you've taken a look at the literature on overprescribing of other medications like opioids to see whether similar themes have emerged.
Yeah, so that is such an interesting question, and absolutely. So and again, particularly in my context, I work in the United States. So I would say the interesting thing about opioids. So certainly there are many of the same sort of relational communicative dynamics that matter, right? And then of course the nature of opioids and sort of what they do to patients, I think is a little. I mean, patients may be addicted to antibiotics in a different way, right? But thinking about the fact, and I've even had clinicians say this to me, that from a policy and regulatory perspective, and also sort of the nature of the public communication about the harms of opioids, that opioids kind of has an advantage over antibiotics because like the harm is very, very visible. And the policy infrastructure, at least in the United States, is incredibly aggressive in some ways that have maybe even made other problems. But I think that so there are similar dynamics, but when we think about the perception of these pharmaceutical agents, that they sort of ring differently in people's minds, and many of the same behavioral economics interventions have been used for both. But I do think opioids have a bit of an advantage in terms of risk perception and regulatory infrastructure, and that antibiotics, I almost think of it having an image problem, right? And so when I talk about doing a better job at capturing and communicating the harms of any one antibiotic prescription, we have to do a little work to do that, as opposed to, in the opioid space. And there's a great intervention that, basically gave clinicians who had prescribed an opioid to a patient who ultimately had an overdose with a letter informing them of that, right? And it changed how they prescribed opioids, right? We don't have something necessarily similar in the antibiotic space, although I do think particularly C. diff is a motivating harm, but it can be difficult to tag that to the prescription, right? So it's all about the way we communicate risk and harm. But yeah, the opioids, it's definitely a comparison case, but the drugs have different things about them that make it harder in terms of communication. But people are definitely thinking about that.
Yeah, I was at a recent workshop talking about dental antimicrobial stewardship, and
Yep.
that concept was brought up, the fact that some of the harms that were caused from those antibiotics are not seen by the prescribers themselves.
Yep.
So there's an
Yep.
opportunity to loop it back there.
Absolutely.
There's a question here about miscommunication between other services that creates a challenges for stewardship programs. For example, when the surgeons are driving, I think they mean prescribing the antibiotics, and the primary team doesn't agree. Um,
Yes.
yeah, these types of complexities.
Absolutely. So that's actually one area that I'm very interested in within, when we talk about medicine and the culture of biomedicine, there are microcultures, and we know different specialties have different norms and beliefs about antibiotics, approach to therapy, what risks are tolerable. And I think that that is something that we definitely see, particularly if you think about in hospital care, as you said, where patients are being cared for by different teams. And there's often a deference, right? Especially, and we see this actually, and interestingly enough, the field of infectious diseases don't always do a good job of stewarding themselves. That's another area that something I'm looking at with my colleagues. But just this idea that you defer to the surgeon, or you defer you've called a consultation with a specialist and they say something that you're like, I don't know if I agree with that, but you feel like you have to follow through on it, right? And again, that's about those social dynamics. And that's why when I make a recommendation about communicating, that stewards do need to consider, again, it's these different constituencies. So the way you engage with your surgeons may be different than you engage with your hospitalists, than you engage with your neonatologist, which is a whole other group, right? And so absolutely. And I think again, it's that you want to do sort of, I've called this sort of bespoke stewardship, where you want to tailor your messaging to those different groups, and acknowledge again that that hierarchy plays a role for sure.
Thank you so much. Very interesting question here about adjusting. Do you think there's any benefit to adjusting our branding of antimicrobial stewardship? Is our branding too abstract or watered down, which may cause folks to not prioritize our efforts and impact accordingly?
Yeah, no, so this is a really important question. And again, I think, I have mostly spent time at these sort of micro levels, but in my work and some policy work I'm doing is really thinking a little bit more about the broader communication strategy of AMR in general. And I think one of the challenges is that AMR is very difficult for people to wrap their minds around, and there's a lot of misinformation. One of the ways that I've thought would be very powerful is again to just sort of think about like what would be lost if we didn't have antibiotics, and so many of the amazing, groundbreaking achievements that we have, for example, in cancer care or a variety of different surgical interventions that we as the public are like, this is incredible that you can do this, but to be able to do this, you need effective antimicrobials. And so I think one of the thinking about this post antibiotic apocalypse, which again, people have argued that that's a little too dramatic. But to me, I often think the most compelling thing is to think about what isn't possible if you don't have antibiotics. That cancer treatment that your parent got, like they benefited from antibiotics. The antibiotics kept them alive in the course of curing their cancer, right? And if we don't have that agent, envisioning a world in which you can't do things that we currently can do. It's like it's a way of getting into progress. So it's a long-winded way of saying that, like, I do think that the threat of AMR is difficult for people to grasp, and sort of the microbial evolution is interesting to scientists, but regular people, superbugs is scary, but that doesn't really resonate. So I do think that that's something that we as a community of stewards need to be thinking about for sure.
Hmm. Even as simple as the term antimicrobial stewardship itself,
Yeah.
it's sometimes not very clear to others, and we think it's clear to us, but not everyone knows
Well,
what an antimicrobial is, for
no,
example.
and I have actually a hilarious story about that is that, like, in the United States, the evolution, like, it didn't always used to be called stewardship. It used to be called antibiotic control, which clinicians hated. And then they called it antibiotic management. And again, this is very US centric, but the era of managed care, people hated that. So it's like, oh, we don't want to be managed. And now it's stewardship, which, to be frank with you, in places where there is more restriction, people are like, it's you're just the antibiotic police, right? But police and stewardship, it's a very different philosophical concept. So I think the branding, even of what it is that we're doing, can be difficult to understand as you described. So yeah.
Thank you. Next question is about, do you have any blueprints on how local public health organizations can communicate and educate physicians about AMR in their area? Thanks for asking this question because we were just plugging something related to this right at the beginning. If you check out Public Health Ontario's website, publichealthontario.ca/ASP, we do have some new resources that are starting to address that exact question. Includes a map of the variability in antibiotic prescribing across local public health units and some tips for how to engage with others within your region about improving antimicrobial stewardship. So it's kind of a first step, and we're hoping to do more work in that area. But I don't know if you have anything that you wanted to add to that, Julie, as well.
Yeah, no, I mean, and just to say that when I was invited so I'm a fan of Public Health Ontario, as someone who has read a lot of Brad's work and sort of looking at Public Health Ontario as kind of a really impressive public health infrastructure. Again, we have, it's different in the US, but that you should definitely check out the resources because they're well produced. And I think part of it in the public health setting is to acknowledge the fact that this is a communal problem, right? And so particularly if you have information on variation in use, really being able to sort of look at those resources and think about sort of how you can even leverage some of those social network effects that I talked about earlier of like, look, we're this real outlier in this way, or oh, look at this other institution that we respect and admire is doing XYZ. So like really, going to those resources, I think is critical. So
Thank you. A question from a person in long-term care. This is kind of an age-old question about
mm,
antibiotic prescribing for UTIs with altered mental status. Easy sometimes to just give the antibiotic rather than
yeah.
to do other assessments, push fluids. Any thoughts on that?
Yeah, I mean, this is one of those very common, I think, challenges, right? Of sometimes the antibiotic is just the easier plan of attack, right? And that doing a little bit more work to manage the patient or take a little more time to ask some questions, you know, if the staff feel that their workload is overwhelming, and they can't figure out how to add in these elements to try to make it in a manageable way, I think part of it is just sort of finding a way to understand like what makes it hard to push fluids or do the better assessment, and then some education about the fact that like while antibiotics seem easy, that is not a course without, the impact for patient harm. And so really trying to demonstrate to people that, while that seems like just this little thing that you add on, that it's not without a negative impact on patients. And so finding a way to make that clear, but then understanding like what is it that's hard in terms of doing the fluids, and so spending some time trying to understand their perspective. And I know every healthcare institution is just strapped for staff. Everyone's overwhelmed. There's not enough time in the day, and that's just the reality. And so finding ways to work within those systems to improve efficiency of making the right thing for the patient the easy thing to do in whatever way possible. But it's a great question.
Thank you so much. I think or at times we do have to wrap up today's session. Want to thank Julie very much for presenting, and thank everybody who joined the webinar. You can expect to receive a brief anonymous PHO round survey for today's session, so please try to complete this. It will help to improve future programming. And as a reminder to everyone, the Ontario Public Health Convention or topic will be held on March 26th and April 3rd in 2024. Check out tophc.ca for details. Lastly, to access PHO presentations and view upcoming sessions, please visit the Public Health Ontario website, head to Education and Events, and click on Presentations. Thank you, everybody, and have a great World AMR Awareness Week.